Welcome everyone. This is Miss Sheridan from Georgia Northwestern Technical College, Floyd County campus. I'll be doing your lecture today on Chapter 4, Physical and Psychological Changes of Pregnancy. Diagnosis of pregnancy. The signs and symptoms of pregnancy are generally grouped into three categories: presumptive, probable, and positive. This slide covers the presumptive signs of pregnancy, which are subjective signs. Presumptive, it's subjective, that a woman notices occurring in her body. They are the least reliable. Sometimes they can be caused by health conditions not related to pregnancy. Many of the early signs are due to rapid rises in the hormone levels that begin in implantation. Usually within 2 weeks after missing the menstrual period, the woman will begin to experience some of these presumptive signs, which include nausea and vomiting, fatigue, urinary frequency, breast enlargement and tenderness, amenorrhea or the absence of a menstrual period, and quickening, fetal movement felt by the mother after 18 to 20 weeks. So presumptive signs of pregnancy are signs where the woman is experiencing some signs and symptoms that makes her suspicious that she may be pregnant. These signs are based on her report of them, so they are subjective data. They are not definite in that they indicate a baby is growing in the uterus, because other conditions could cause these presumptive signs. For example, PMS is very similar to these signs. However, a woman could presume she may be pregnant. Make sure you're familiar with these presumptive signs of pregnancy outlined here. I will have a mnemonic for you on the next slide to help you recall these. Here's a little mnemonic device you can use to help remember the presumptive signs of pregnancy. Remember, these are all subjective. You can remember the word presume. That's going to be your word to remember the mnemonic. P standing for period absent or amenorrhea. R for she's really tired, fatigue. E for enlarged breast. S, sore breasts. U for urination increased. M for movement of the fetus and uterus. The woman perceives a fluttering in her lower abdomen. That's called quickening. Quickening can occur as soon as 16 weeks for second-time moms and around 18 to 20 weeks for first-time moms. And then E, emesis and nausea. Probable signs of pregnancy are objective signs. They can be detected by a healthcare provider during a physical exam, or it can be evaluated by a laboratory test or an in-home pregnancy test. Probable means likely to be the reason. Probably, very likely. These are pregnancy signs that the nurse or the doctor can observe and document, hence being objective. However, these probable signs do not 100% mean that a baby is growing in the uterus. It's possible it could be due to other causes. These signs include Goodell's sign, which is a softening of the cervix, Chadwick sign, a bluish purple coloration of the vaginal mucosa and cervix, Hegar sign, softening of the lower uterine segment, ballottement, where the fetus floats away from the cervix when the cervix is pushed, and a positive pregnancy test detecting HCG, the pregnancy hormone, around day 11 of gestation or so. The next slide, I will have a mnemonic device to help you remember these probable signs of pregnancy. Here's your probable signs of pregnancy mnemonic. The word to remember is probable. P standing for positive pregnancy test. R for returning of the fetus. Talking about bouncing back of the fetus against the fingers when the uterus is pushed during palpation. That's termed external ballottement. Outline of the fetus can be palpated. B for Braxton Hicks contractions or false labor contractions. These are not regular in rhythm, and they're not going to result in cervical dilation. A for a softening of the cervix, which we call Goodell sign. It happens around the 6th to 8th week of gestation. B for bluish color to the vulva, cervix, and vagina due to increased blood flow. It happens around 4 weeks gestation. We call that the Chadwick sign. L for lower uterine segment becomes soft or Hegar sign. Happens around 6 to 12 week gestation. E for enlarged uterus. All of these probable signs of pregnancy are important to remember. And I do want to make sure that you remember the different signs, Goodell, Chadwick, and Hegar sign. Positive signs of pregnancy. This is only attributed to the presence of a fetus. With positive signs of pregnancy, we are positive that a fetus is present. This is when an experienced healthcare provider is able to confirm the presence of the fetus. Positive signs include fetal heart auscultation by a Doppler, fetal movement felt by an experienced practitioner, an ultrasound used to verify an embryo or fetus. On the next slide, I'll have a mnemonic device to help you remember these positive signs. Remember, positive signs of pregnancy are only indicated due to the presence of a fetus. We are positive there is a fetus present. So the word to remember, your mnemonic device, is fetus. F for fetal movements felt by the doctor or an experienced nurse. E for an electronic device detecting fetal heart sounds, your Doppler. T for the delivery of the baby. U, ultrasound detects the fetus. And S for C, visible movement of the baby by a doctor or a nurse. Those are your positive signs of pregnancy. Here's an outline of the different diagnoses of pregnancy. You've got your presumptive, probable, and positive signs of pregnancy. This outlines it all here for you. This is a really great YouTube video that covers all the normal physiological changes in pregnancy. It's a really good video, and it outlines all the different system changes in the body just all the body systems, and it'll cover the wide span of the tables in your book. Like it covers tables 4.1 all the way to, let's see, 4.7. So it covers like pages 40 to 49 of your book. It's a really good video that summarizes and outlines the key points of the changes of each body system. I would highly recommend that one. I will link it to your Blackboard as well for you to view, since there's no way for me to play this video during this recording. We're still going to talk about the different system changes in pregnancy. These are mentioned in the video as well. Table 4.1 on page 40 starts with the reproductive system changes, and I'm just going to cover like highlights. Important things to know here is that the uterus is starting to expand to accommodate this growing fetus, the placenta, the umbilical cord. It covers 50 to 100 milliliters of amniotic fluid and the fetal membranes. Your cervix, that's all the changes we talked about with the probable signs of pregnancy. You have your Chadwick sign, which your estrogen's causing your cervix to become congested with blood, and it causes a bluish purple color to the cervix, vagina, and the labia. I think of Chadwick sign as purple chapstick. Chadwick and chapstick, it just makes me think of the word chapstick. So I just equate it with like a bluish purple chapstick. That's how you can remember it. Softening of the lower uterine segment, that's your Hegar sign. Estrogen and progesterone cause cervical softening by decreasing the collagen fibers. It also increases the vascularity and edema, which is Goodell's sign. Cervix starts to soften, preparing for dilation during labor and childbirth. Cervical mucus forms a plug in the cervical canal. The closed cervix with the mucus plug prevents bacteria from entering the uterus. Loss of this mucus plug and bloody show are early signs of labor. The vagina and vulva, changes with those is that you have an increased vascularity. They're getting more blood flow, blood supply to the vagina and vulva, so they appear bluish. There's that Chadwick sign again. The bluish purple chapstick, Chadwick. Vaginal mucosa thickens. It becomes much more soft, and the connective tissue softens as well so that it can expand during childbirth. Now, this does cause rapid sloughing of cells, so the woman may experience increase in vaginal discharge. You want to reassure her that the increased vaginal discharge is normal, and it may increase as the due date arrives, so she shouldn't be alarmed at that. Now, you do want to teach your pregnant patient signs and symptoms of vaginal yeast infections because she is more prone to that being pregnant. And that's due to the increased levels of glycogen present in the vaginal cells. It makes the environment more favorable to the growth of Candida albicans, which is a yeast. So you're going to teach her signs and symptoms of a vaginal yeast infection, like increased vaginal discharge that is white, thick, cottage cheese-like, and vaginal itching. She should report those to the healthcare provider right away. As far as the ovaries, the changes with the ovaries, After ovulation, that LH hormone stimulates the corpus luteum. Remember, the corpus luteum is a mass of cells that forms in an ovary, and it's responsible for the production of the hormone progesterone during the early pregnancy. Now, sometimes cysts can form in the corpus luteum, which can lead to painful symptoms for the woman. The corpus luteum continues to increase in size during, the period of time of pregnancy, and sometimes those cysts can rupture, causing the woman a lot of pain and vaginal bleeding. So you want to advise her to contact her healthcare provider if pain or bleeding is occurring. Breast changes. So there's an increase in blood volume in the breast tissue. Estrogen and progesterone cause breast enlargement. She may feel some tingling, increased sensitivity in her breast. During the second trimester, colostrum develops. You want to reassure the woman that leaking colostrum is a normal process of the breast preparing for lactation and not to be alarmed. She can wear a supportive bra or pads just to prevent leakage. Sexual activity. So during pregnancy, there's an increase in vaginal lubrication and an increase in the blood flow to the vaginal area. Reassure her that the woman and her partner, that sexual intercourse will not harm the fetus. Respiratory system changes. This is table 4.2 in your textbook on page 42. The respiratory rate will increase 18 to 20 respirations per minute. Oxygen consumption increases by 20%. So that provides for the extra oxygen demands that the fetus requires, as well as the placenta and the uterus. The pregnant woman may feel short of breath very easily when she's lying down and with mild exertion. Now, the shortness of breath with mild exertion should be more towards the end of pregnancy, like third trimester or the end of the second trimester. If the woman's experiencing shortness of breath like in the first trimester or the very first beginning portion of the second trimester, she should be seen by her doctor. It may indicate a problem that would require further assessment. To reduce the feeling of shortness of breath, you could teach your patient to elevate her head on an extra pillow at night and to walk up the stairs more slowly. Teach her that rest periods are okay. A pregnant woman is going to breathe faster and more deeply. And it can cause a feeling of nasal and lung congestion. I know I had a lot of nasal congestion when I was pregnant. So she needs to be educated regarding the normal changes and reassurance. She could use a cool mist humidifier to help her. She wants to blow her nose very gently, nothing harsh. We don't need to cause nosebleeds or anything like that. And avoid overuse of nasal spray decongestants. So if you overuse nasal spray decongestants, it can cause a rebound effect of prolonged use. So it can make the problem worse. Now, the nasal decongestant spray, like a common example I could think of is like Afrin. You don't want to overuse that, or it can make the problem even worse. It's going to close it up even more. A common medication like Flonase doesn't contain that decongestant, so the rebound phenomenon will not occur with that. That is safe, but you want to use it per the package instructions. You still don't want to take it too much. If she does experience frequent nosebleeds, she should notify her healthcare provider and be evaluated. Just take note that later in the pregnancy, the enlarging uterus will cause an upward pressure and elevation of her diaphragm, and the cartilage and muscles relax. The chest starts to broaden to allow more room for that enlarging uterus. So her chest circumference may increase by as much as 6 centimeters or so. For cardiovascular system changes in pregnancy, there's an increase in circulatory blood volume that begins by week 6. It will reach 50% more than the pre-pregnancy volume. So you see an increase of blood volume in pregnancy. There's 500 mils of blood that's needed to provide for increased oxygen consumption of the growing fetus and the uterus, the breasts. On assessment, you might notice a slight cardiac hypertrophy, so the heart could enlarge, as well as an asymptomatic systolic murmur, and that is due to all that expanding circulatory blood volume in pregnancy. Always inform the pregnant woman she should avoid the supine position. Laying on her back can cause feelings of lightheadedness, can cause her blood pressure to drop. We call that supine hypotension or Vena Cava syndrome. She wants to lie on her side to provide for better brain and placental perfusion. You want to teach her to lie on her left side so that she will not experience this Vena Cava syndrome. The heart rate increases 10 to 20 beats greater than pre-pregnancy levels. Blood pressure's, normally remaining stable, even though there is an increase in the blood volume. She may experience varicose veins during pregnancy due to that increased blood volume. As far as blood components, you have anemia that occurs very often in pregnancy. So in pregnancy, the fluid portion of the blood increases, which dilutes the red blood cells, so it makes it appear anemic. So she's going to appear lowered hemoglobin, lower hematocrit, lower red blood cell count. She may experience fatigue, hair loss, or pica, which is an abnormal craving for non-food substances like ice, dirt, paint, or clay. If the pregnant woman is experiencing anemia, she is likely to be prescribed an iron supplement. That's usually prescribed to pregnant women by the second trimester or so to prevent anemia. She should be taught to include iron-rich foods like red meat, spinach, kale, broccoli, and raisins. She is at a high risk of venous thrombosis or blood clots, so teach her the signs and symptoms of blood clots like warmth, redness, swelling of her calf, and she should notify the healthcare provider immediately. Avoid sitting or standing for too long of a time to prevent venous stasis, that blood sitting in one spot for too long. The blood starts pooling, and blood clots or venous thrombosis are known to form. On page 44 of your textbook, I just want you to highlight 2 lab values there for me. Highlight red blood cells, RBCs, and in non-pregnant women, the level is 3.91 to 5.11. For pregnant, there is no change. And then go down to the platelet count and highlight that one. In a non-pregnant woman, it's 150,000 to 450,000. In a pregnant woman, it's less than 150,000 due to the hemodilution. So there's an increase in the fluid portion of the blood that makes the platelets diluted. So it's lower in pregnancy. I just want you to take note to those changes and know those normal lab values for red blood cells and platelets and the differences in pregnancy, what might occur. Your GI system changes. So there's, heartburn that might occur. So you can instruct her to eat several small meals instead of 3 large meals to help keep her stomach from being empty. That's good for nausea. She needs to eat bland foods if she's experiencing a lot of heartburn. Things that are low in fat, easy to digest, like cereal, rice, bananas. Avoid lying down directly after a meal and avoid overeating. For nausea, she could try eating dry toast, saltines, or dry cereals before getting out of bed in the morning, sipping on some water or a clear soft drink like Sprite. Avoid smells that upset her stomach. And they also say lemon drops help. Constipation is also a known problem of pregnancy, so teach her to drink her 8 to 10 glasses of water a day. Eat her fiber-rich foods like raw veggies, fresh or dried fruit, whole grains. Increase her physical activity. Teach her to avoid straining too, because hemorrhoids are also a problem. So she needs to notify her healthcare provider if hemorrhoids become very painful or if they're bleeding. Increase fiber and fluid intake to avoid straining. And just reassure her that hemorrhoids usually will improve after delivery. Pregnant women in their late 2nd and 3rd trimester may experience a condition called superior vena cava syndrome. These symptoms occur when the inferior vena cava gets compressed by all that pressure from the fetus in the enlarged uterus. So this leads to decreased blood return to the heart, decreased cardiac output, which will decrease the woman's blood pressure, leading to hypotension. It will in turn decrease the perfusion to the placenta, which decreases oxygenation, that perfusion, blood supply, oxygen, nourishment to the fetus. So if this is not corrected by having the mother turn to her left side, the fetus can begin to show signs of distress and start to decelerate with their fetal heart rate. So you want to teach the woman to turn on her left side. Turning on the left side helps relieve the inferior vena cava compression in the pregnant woman. Early symptoms of supine hypotension, also called vena cava syndrome, are tachycardia, because the heart is working overtime to try to get the blood back to the heart to perfuse the placenta and the fetus. She can feel dizzy, lightheadedness, or feeling very faint, nausea, and sweating. So you can see here with this picture, the vena cava and the aorta are pressing down by the weight of the fetus and the uterus. So if she turns on the left side, the compression is relieved. We talked about the blood component changes on a previous slide, but I just want to reiterate that with a normal pregnancy, your blood volume increases, so it results in what we call hemodilution. This is occurring due to the increased volume of the fluid portion of the blood, that's your plasma, and that is causing what's called physiological anemia of pregnancy. So, in other words, with normal pregnancy, your blood volume is increasing and the red blood cell mass is increasing during pregnancy, like you have an increased blood volume. However, the plasma volume increases more than the red blood cell component. So it results in a relative anemia. That's called the physiological anemia of pregnancy. And it's just saying that that fluid portion of the blood is increasing even more than the red blood cell mass. So the fluid portion of the blood, your plasma, is increasing in pregnancy, which is diluting your red blood cells. So there you have your anemia, the reduction in red blood cells, where she can experience symptoms of anemia like fatigue and hair loss, or may experience pica, like eating ice is very common. This is the visual I want to show you for the physiologic anemia of pregnancy. So this right here shows you like the normal components of blood on a non-pregnant patient. That's this one right here. Now with pregnancy, especially your third trimester, you see your red blood cells increase a little bit compared to non-pregnant, but your plasma increases a whole lot. So it dilutes the red blood cells. Iron supplements are commonly prescribed during pregnancy for anemia. And NCLEX loves to ask about iron supplements. So this is a really good drug facts table that your book has. These are some nursing implications to keep in mind about iron supplements and how to teach your patient when it's newly prescribed. So for best absorption, she should take the medication 1 hour before or 2 hours after a meal. Absorption is actually improved if it's taken with orange juice. So that's one thing you can teach her. If she has gastric irritation, it can be taken with meals. You want to teach her not to be alarmed that her stool may become dark green or black. Also, she can include iron-rich food like red meat, leafy greens, broccoli. Changes in the urinary system due to pregnancy. So with the urinary system, you have your kidney workload increasing due to that increased circulatory blood volume and cardiac output. The effect of the hormone progesterone on the renal pelvis causes dilation and distension, which can lead to urinary stasis, where the urine stays in one place, it pools in one place, and can lead to bacterial growth, which can lead to possible urinary tract infections. She may experience UTIs during pregnancy, and symptoms like urinary urgency, frequency, and dysuria, which is painful urination. The nurse should monitor the kidney function test, the creatinine, the BUN for abnormalities and report them to the doctor. And since the woman is increased risk for UTIs, you should teach her signs and symptoms and when to be seen by the physician. Temporary bladder control problems are very common in pregnancy due to that enlarged uterus and that fetus pushing down on the bladder and the urethra. It can cause some incontinence, some more frequent need to urinate since it's pressing down on your bladder, making you feel like you need to urinate more often, as well as incontinence, that leaking of urine when sneezing, coughing, or laughing. Encourage her to take frequent bathroom breaks, to increase her consumption of fluids to avoid becoming so dehydrated, and instruct her on performing Kegel exercises. And there's some patient teaching in your book on Kegel exercises. It is on page 41 in Patient Teaching Guidelines box. So you're going to teach her to rapidly contract and relax the muscles of her perineum and the vagina for 10 seconds. Relax for 20 seconds. Repeat that routine and teach her to repeat that, and should be increased gradually to between 50 to 150 times per day. Integumentary system changes in pregnancy. You have hyperpigmentation occurring due to the elevated levels of those hormones, the estrogen, progesterone. You can see what's called melasma. That's called the mask of pregnancy, which are brownish patches on the forehead, cheeks, and nose, which you can see here in this picture. You have linea nigra. That's a hyperpigmented line right there that can extend from the symphysis pubis to the fundus. On the breast, your areola may darken. Educate your patient that melasma increases with exposure to the sun, so she wants to use sunscreen to reduce the severity. And hyperpigmentation usually disappears after childbirth. Of course, stretch marks are extremely common during pregnancy, called striae gravidarum. Can occur on the abdomen, the hips, thighs, breasts. They can also be red and sometimes itchy. And there is no documented proof that creams that advertise that they prevent stretch marks or erase stretch marks actually work. Creams may soothe the itchiness, but there's really not any one cream that's going to completely erase the stretch marks. You might see pruritic urticarial papules and plaques of pregnancy, short for PUP, P-U-P-P. On page 48 there, it's the most common pregnancy-specific dermatosis. And it's a rash that appears on the abdomen and occasionally involves the extremities. They're itchy plaques and papules with red patches. Usually develops in the 3rd trimester, and they give oral antihistamines and topical corticosteroids for that. You can reassure her that the rash will disappear after childbirth. Musculoskeletal system changes in pregnancy. Of course, you have postural changes due to that growing uterus. The upper spine extends to help support that growing uterus and gives the pregnant woman a sway back appearance, which can lead to backaches. Teach the woman to practice good posture, wear low-heeled shoes, high heels are not recommended, sleep on her side, use heat, cold, or massage to manage the backache. Loose joints, the effects of relaxin, which is that pregnancy-related hormone we talked about in Chapter 3, affects the joints and the symphysis pubis, causing them to soften and stretch. So she may feel clumsy, may experience a waddling due to the laxity of her joints. Teach her to lift with good body mechanics and to wear low-heeled shoes. Pregnancy and childbirth is considered a life transition period. It's a maturational crisis. And you as the nurse should understand how there are a lot of factors that influence the pregnant woman. It could be her access to health care. It could be her baby's father and siblings, how the grandparents react to the news of the baby. It could be financial issues or family support or lack thereof, availability of daycare, transportation, and any previous experiences she may have had with childbirth and child rearing, some of which may have been traumatic. So there's lots of different factors that influence. Psychological adaptation to pregnancy. Reva Rubin was a nursing theorist who wrote of the mother's experience of pregnancy, childbirth, and maternal identity. Her innovative and now classic writings describe women's cognitive work during pregnancy, like how mothers think, in addition to how describing nursing care of the pregnant woman impacts the care. Reva Rubin identified 4 maternal tasks that the woman strives to accomplish during pregnancy to lead to maternal identity. We're going to be discussing each of these 4 maternal tasks on the following slides. According to Reva Rubin, the first maternal task is ensuring safe passage for herself and the fetus. During the first trimester, the pregnant woman expresses concern for her own health and her pregnancy symptoms. Safe passage is associated with trying to protect the child and herself from danger. Seeking prenatal care and obtaining information about pregnancy and birth reflect the working through of this first maternal task. She has concern for her own health and pregnancy symptoms, rapidly changing emotions due to the hormones. She's seeing other mothers and other pregnant women, getting information on the internet, maybe ambivalent about the pregnancy, seeking competent prenatal care, engages in healthy self-care such as avoiding alcohol consumption, eating healthy. The reality of pregnancy often causes introspection during the first trimester. As she adapts to the physical changes, she looks at her life and wants to be the best she can for this child. Seeking acceptance of the child by others. This is the second maternal task, according to Reva Rubin, where the woman is seeking support and acceptance of this pregnancy by the woman's partner and the family. She desires their acceptance and her developing maternal identity. She wants, like if there's any other children in the family, she wants to build acceptance of the new baby's arrival. This is going to involve lots of adjustments in that family dynamic, as well as the psychological, social, and physical space within the family to make space for that child that's on the way. A pregnant woman's relationship with her own mother is very significant in how that woman adapts to pregnancy. As the pregnant woman's mother reminisces about her pregnancy and her daughter's early childhood, it helps the pregnant daughter anticipate and prepare for pregnancy, labor, and motherhood. An absence of a mother figure is going to impact this task. So the second maternal task is all about seeking acceptance by others. The third maternal task, according to Reva Rubin, is bonding with the infant. So the mother's beginning to develop a bond of attachment and feeling of love for the infant. She feels the fetal movement and the intimate connection with that unborn baby. She also observes women mothering their children and reflects on her own style of mothering. But it's that bond between mother and child that for some women is apparent immediately. The sense of birth of already, being so in love with that child. The fourth and final maternal task, according to Reva Rubin, is committing to the child through pregnancy, kind of giving oneself. This is the final task and marks the beginning of a mother's nurturing behavior to her child. She learns to meet the needs of another being before herself. She starts to prepare for the baby, getting a nursery together, getting baby items. She might read books on newborn care and parenting. Pregnant women undergo psychosocial changes throughout the pregnancy. Unsuccessful resolution of those changes are associated with difficulties in pregnancy, delivery, some cases child abuse, neglect. There's a cultural considerations box in your textbook. It talks about Chinese and Indian cultures. Pregnant Chinese women may assume a sick role in which they depend on others for assistance. They also believe that pregnancy disrupts the cultural belief regarding the need to balance hot and cold, that yin and yang, which is vital for sound health. To manage the disruption and balance, the pregnant women may eat special soups and chicken broth to try to balance out the yin and the yang. Indian women view pregnancy as a normal process that does not require any intervention by healthcare professionals. Some Indian women believe it's the responsibility of others to satisfy a woman's craving. There's also a belief that if a newborn baby drools excessively, the mother's cravings were not met during the pregnancy. And one thing to remember about all these cultural considerations is that not everyone of a certain culture will behave in the same way. Everybody is different. This is just a generalized view of the different cultures. The pregnant Japanese woman does not discuss morning sickness even with their family. They're usually advised to avoid activities that require concentration. They believe that epinephrine released with mental stress may harm the baby. They have a tradition for the woman to move to her parents' home in the 8th month to prepare for delivery. Hispanic women are encouraged to stay active during the pregnancy. It's believed that this will lead to a healthier baby. They're very respectful of their elders, and they will often look to their mothers, aunts, and grandmothers for advice on the pregnancy. The pregnant adolescent has a lot of psychosocial changes happening. They're completing developmental tasks of adolescence and those of becoming a mother, which is very stressful for them. Their priorities are very typical for their age: their appearance, peer group, focus on their own needs. They may tend to keep their pregnancy a secret. And one thing you definitely want to teach is to make sure she seeks prenatal care, because she may be hiding the pregnancy. Denial until late in gestation is very common in the pregnant adolescent. The nurse needs to assess the developmental level and the support system of the adolescent. All these things in red here are important. She may experience anxiety informing her parents, the father, their friends. She may feel ambivalent towards the pregnancy or some resistance. Typically, the most important person to the pregnant patient is the father of the baby. The mother has a need for the father to accept the child, and the father's role is important in the couple's and family's adjustment to this new baby. Some men actually experience physical changes called Cava syndrome. It's called being very sympathetic. It's a sympathetic response to the pregnancy, where he may gain weight or experience nausea. In the first trimester, he may feel ambivalent towards becoming a father or towards the new baby. Or he may have strong protective feelings of nurturing and protecting the woman. As the pregnancy goes on and progresses, he may be concerned about his ability to be a good father and examine his own father-child relationship. Very similar to the Reva-Rubin task, where, the pregnant woman is looking back at her bond with her mother. If the pregnancy was unplanned or unwanted, some fathers may not be ready to accept changes in lifestyles or life plans. Many men eventually adjust to the unwanted pregnancy and begin to look forward to becoming a father. Domestic violence has become an issue during pregnancy, and the American College of Obstetricians and Gynecologists suggests that screening for domestic violence should be done at each prenatal visit. For the siblings of the new baby, this could be a major crisis for them. Their world is changing. The siblings' response is very influenced by the child's age, what developmental level they are, the parents' attitudes, and how prepared they are for the upcoming birth. You can help prepare, especially an older child, for a new sibling by starting to talk to them about the arrival of his or her new sibling. Explain in age-appropriate terms how the baby is growing. Ask him or her to help you set up the nursery, for example. Some hospitals have sibling class designated for children and parents to learn together about what it means to become a new sibling. Explain to the older child that the baby will eat, sleep, and cry for most of the time. The baby won't be a playmate right away, but eventually when they grow, there'll be a playmate for them. So you definitely want to take into account the developmental level. Toddlers can become very clingy and irritable. They may not really understand that the baby is happening. It may be more like a story to them, not a reality, especially if they're informed of the pregnancy too early before the woman is showing. A preschool child may have a sense of loss, be very jealous. Older children are interested. They may have a lot of questions, especially about conception and how to get pregnant, childbirth. Older children and teenagers may be embarrassed by their parents, just thinking about their sexuality of their parents. Older school-age children might help plan and help try to be helpful in ways that they can prepare for the new baby in the home. With the news of the arrival of a grandchild, most expectant grandparents are very pleased with the possibility of a new baby. It causes them to reflect back and remember their own experiences of pregnancy and raising children. They may recall the first of their child, like their first words or first steps, and they share those memories. The grandparent support and presence will strengthen that family and provide support to the parents-to-be. Non-support would add stress and decreases the self-esteem to the parents-to-be.